Yeah, go ahead. It's just 7 o'clock now. Go ahead and feel free to introduce yourself and go right ahead.
Excellent. Well, thank you to this group and the organizers, Dr. Altman and Ayers. My name is Ian Humphreys. I'm one of the rhinologists here at University of Washington, and it's really a pleasure to be back here speaking and engaging with this group. 3 years ago, I had the opportunity to talk about polyps and phenotypes and endotypes as it relates to CRS, and it's sure exciting to see where we've gone, where we're going, and all the future innovation and collaboration that we have in this space. So it's really rewarding and a joy for me to be back here with this group. It's inspiring to work with you and collaborate with you on patients. And so thank you again for the opportunity to be here. I do want to share a little bit about our group in Rhinology in that we continue to grow. And I really want to take a moment and just kind of celebrate that growth and share with you some of our additions to the faculty as well as our division. And I'm pleased to announce that we've recruited 2 outstanding faculty members to our division in Sinus Center. And the first is Walid Abizaid. Walid finished his fellowship at Stanford and for the last 6 years has been at Montefiore Einstein as a rhinologist and director of the rhinology and skull-based program there before we recruited him last fall. Walid started with us in May and is up and running and seeing patients. He's also overseeing our research program. So he's truly an incredible asset to our program and part of the growth that I'm pleased to share with you today. Arya Jafari is also joining us soon. He's finishing this week, so congratulations to Arya, his fellowship at Harvard Mass Eye and Ear in rhinology and skull-based surgery, and he'll be joining us starting September 1st. So we really look forward to Arya joining us and rounding out our complement of faculty surgeons. You may have worked with Jamie Young in the past. Jamie is a nurse practitioner, has been part of our department for about 4 years. We aligned Jamie to the Rhinology and Sinus Center about a year ago. So she's exclusively practicing rhinology and sinus care and has been an incredible asset to our team in enhancing our systems, our programs, access, as well as communication. So really we'll acknowledge Jamie and all the effort she pours into our division and our service line. So thanks to Jamie as well. We have 2 sites of practice that you may be familiar with. As you may be aware, University of Washington has 2 centers now at its main campus, the Northwest and Montlake campuses. The Sinus Center is based historically out of the Montlake campus, which you'll see here in the U district. But we also established a presence over in Bellevue about 4 years ago at the East Side Specialty Center, which is right on North Up Way. And our UW Allergy group's familiar with that area, of course, and we have a rich history of collaboration with those faculty members in that area. Well, we plan to expand in other regions, but for now, this is where our Sinus Center is based, and we really look forward to continued collaborations with all of you in the community as well as here at UW. When I was approached to talk today, the discussion point, I think, came out of some of our clinic experiences. And many of you may know that Drew and I run a combined sinus and allergy clinic together where we see the patients concurrently. And really, this was born out of what we feel perceived as a need for our advanced and difficult to treat sinus patients, our AERD, our patients that were non-AERD, but we were considering biologic therapies, as well as our immunodeficiency or immune compromised patients, where we really felt, rich collaboration and coordinated care was the future. And we established that approximately 4 years ago. And as that continued to grow and develop, trainees began spending time in those clinics, particularly our rhinology fellow, as well as the allergy fellow. And what we recognized is besides cross-pollination of ideas and research ideas and patient care was areas of interest, particularly for our trainees, and learning what our colleagues do and what's everyday part of their practice, but may not be familiar to our practice. And I think one of the areas that we emphasize from a rhinology perspective is our powerful tools of endoscopy and imaging, and how we consider those tools both in the diagnostic evaluation of patients with sinus disease in particular, but also how we use that in the construct and paradigm of surgical decision-making and care. And so when I was approached today to talk about how we think about endoscopy and imaging, I began thinking, well, how can I frame this in a way that doesn't feel like it's just a discussion of endoscopy and imaging, but also incorporates perhaps some new ideas or new topics or new areas of innovation in an area that is relevant for both of our practices. And so that brought me to the idea of central compartment atopic disease. And this is I call this new views of an old problem, as the problem is certainly not new. The appreciation, the name, the labeling, the phenotype descriptor to it, however, is new. And I'll go through central compartment atopic disease. And from here on forward, I'm going to refer to it specifically as central compartment, just for brevity and efficiency in the talk. But I'd like to present that as a construct today of how I discuss how we use nasal endoscopy and imaging, hopefully draw attention to this newer phenotype of sinus disease, and bring awareness to ongoing areas of development in this particular space and the tools, again, that we use to do that. The challenge for those of us that engage into sinus disease on a daily basis, but also in collaboration with our peers, both in allergy, immunology, pulmonology, and oftentimes even rheumatology and infectious disease, is that chronic sinusitis has many different forms of presentation. And unfortunately, we don't have well-designed or established biomarkers for this condition. We don't yet have genetic testing. And so that talk 3 years ago that I gave about endotypes and phenotypes is still relevant today. And what I hope to share is a perspective for us as otolaryngologists in general, but rhinologists in particular, of the tools we use to try to help us in our decisions, particularly as it relates to surgery, to phenotype these patients, and the tools we use to do that. And on the top line, you'll see here an example of what is an otherwise normal patient that does not have either allergic rhinitis or chronic sinusitis. And the three tools that I think we rest heavily on in our space is the history, sometimes laboratory data, but certainly we weigh heavily on endoscopy and imaging. And part of that is driven by our guidelines, which are established for the diagnosis of chronic sinusitis. And the diagnosis of chronic sinusitis for us, according to our guidelines, is predicated on the proof of inflammation in the sinuses. And that proof of inflammation can be established in one of two ways, either with endoscopy or with imaging. And so there's an inherent emphasis for us both on guidelines, but also our evidence, and where the rubber meets the road, what we have in our practice, in our offices, in our clinics every day, to emphasize endoscopy and imaging. And so it's a very powerful tool for us. We use it to help prove the idea or the disease of chronic sinusitis, but then we further use it to qualify what we perceive as the phenotype of chronic sinusitis that hopefully gauges how we move forward in our medical decision-making, our surgical decision-making, as well as collaborations with colleagues. On the bottom panel, you'll see a patient with a history that's consistent with chronic sinusitis, asthma, and perennial allergic rhinitis. In the middle panel, you'll see an endoscopy right here. And in this endoscopy, let me orient you here for a moment. This is the patient's left side. The arrow is showing the nasal septum. Over on the right side of the image is the inferior turbinate. This whole space would be the nasal cavity, but it's filled with this polyp material sitting here that's extending down towards the nasal floor as well as towards the inferior turbinate. Further superiorly, you'll see additional polyp tissue, and you see a hint of the middle turbinate. And this space right here is the middle meatal space. And so these are the areas that we tend to look at with endoscopy. As if you compare it to the image above, there's clearly a stark contrast on endoscopy between these two patients. On the bottom right panel, we see the CT scan of this patient. And we're going to introduce concepts for CT scan regarding opacification. And we have total or partial or complete opacification. The descriptors imply similar concepts in terms of the extent of opacification within the sinus, and opacification being defined as the radiopaque of nature of the sinus itself or the nasal cavity and meatal spaces. And you can see a stark contrast between a normal subject who has no evidence of opacification within the maxillary sinus versus somebody that has complete. Other labels that we use when we review the imaging include mucosal thickening, how the bone is handled around the sinuses, whether it's thickened, and we often refer to that as either osteitis or osteoneogenic change. You can see a nice example of that right through here. And then just the topography of the disease. What sinuses does it involve? Does it involve the maxillary, the ethmoids, frontals, and sphenoids? Does it involve two of those sinuses? And so we use these descriptors to try to put a sense together of the severity of the condition, but also the phenotype of the condition. And let me show you a similar patient on the top panel here who has the same diagnostic codes. So the ICD-10 codes in this patient would be exactly the same. The endoscopy could look exactly the same as the polyp patient I showed on the previous slide. However, the imaging looks significantly different. A few points of interest that are different on this patient is not only is there a complete opacification of all the sinuses in the nasal cavity, but you can also appreciate within that opacification, there are differences of how the tissue is appearing on imaging. There's these more bright white areas and more darker gray areas. We often call this a double density. And there are a few different things in our differential that we consider when we see these changes on imaging. That includes eosinophilic mucin can have this appearance. This can include fungal ball, or the older term would be mycetomas within the sinus itself, or it can be concretions and collected debris, oftentimes seen in chronic biofilm patients. So there are a variety of different factors that it could represent, but it is a different phenotypic presentation of otherwise a similar patient, at least in terms of ICD-10 codes and how we would see them on endoscopy. Clearly, these patients are different in their biology, but when we don't have discrete biomarkers that are currently available or genetic testing that have reconciled these answers, this is why particularly us as otolaryngologists weigh heavily on these factors to help guide our decision making, particularly as it relates to surgery. So the newer topic is the central compartment, and on paper and ICD-10 codes, they would still look similar in many regards. However, what is different for these patients and why it's been proposed as a different phenotypic entity of chronic sinusitis is this is an endoscopic view of a patient with central compartment. If I orient you here, this is the left side of the patient's nasal cavity. This is the septum, the outside lateral wall. This is the middle turbinate. And these are polyps that are confined and organized immediately in this area. This is an area of focus for us as it's called the middle meatal space. And I'll highlight in further slides why that's important to us. But in short, this space is critical. And the reason why this space is critical is it's where the maxillary, anterior ethmoid, and frontal sinuses all drain. So we really emphasize this space as surgeons, one, because that's the confluence area for 3 of the 4 sinuses on a given side, but also it's the passageway, the delivery, the portal for delivery of topical therapies into a patient's paranasal sinuses. So if this space is occluded, distribution of drug, whether it's saline irrigations, intranasal corticosteroid sprays, topical steroid irrigations, antibiotic irrigations, antihistamines, whatever they may be, distribution of drug into these areas will be impaired. And that is why perhaps this phenotypic entity of central compartment is important, is that it tends to isolate polyps immediately in these areas right in the middle meatal space. If you look at a patient's representative imaging with central compartment, you can immediately see the differences as compared to the patient who otherwise would have the same ICD-10 codes, but is clearly a different biologic process. If a few points to discuss immediately are that the paranasal sinuses laterally tend to be well aerated, represented by black, and the central areas within the paranasal sinuses have degrees of opacification. So here are degrees of opacification as viewed through the ethmoid sinuses. You can see that it's not complete opacification. For example, here's an ethmoid air cell that is pneumatized or aerated, another aerated cell here, an aerated cell here, but there's certainly opacification through many of these areas within that central aspect of the ethmoid sinus. But when you look laterally, maxillary sinus, or into this space, which is called a supraorbital ethmoid cell, they're well aerated, which is clearly different phenotypically than a similar patient in terms of ICD-10 codes with chronic sinusitis with polyps. So this is not new for us. We've known that these patients are different. We know that they behave biologically different. We know that outcomes can be different, We know that their management strategies, both medical and surgical, can be different, but this specific phenotypic entity wasn't called out until 2014. And so I hope to use this as a bit of a paradigm and framework for our discussions today as we go deeper into endoscopy and imaging. Again, a representative view of central compartment with a comparison normal nasal endoscopy, just highlighting and emphasizing again those changes that occur in this space in the middle meatus, which would be represented here on the normal nasal endoscopy. So the old question was really, how much does a role does allergy have in the pathophysiology or the etiology of chronic sinusitis? And this is a conversation that has been going on for quite some time. In our literature, it's debated to what degree of causality allergy has specifically in chronic sinusitis. And I'm not specifying those with and without polyps. So I'm using chronic sinusitis in a general sense. And if you look at our literature, when you distill it down, particularly into this statement right here, which was really a landmark paper for us in Rhinology, it was a group of researchers from around the world, clinician scientists, both from allergy as well as in rhinology, otolaryngology in general. And what their conclusions were when we look at that old question of how much does allergy have a causal role in the pathophysiology of chronic sinusitis, their conclusion was that it was equivocal in terms of the data, that there were studies that suggested there was a discrete etiologic role in chronic sinusitis, as well as studies that refuted that idea. What is an interesting discussion around this idea, however, is that we acknowledge that there are many forms of chronic sinusitis. I think that is a statement that we can all agree on today, that the endotypes and the phenotypes are different, that there are clearly different biology amongst different chronic sinusitis patients, even particularly those between non-polyp and polyp patients, but even within our polyp patients. And it may be that allergy has a driver or a larger role in certain phenotypes, more endotypes of chronic sinusitis than others. And that when we look at the data that we have, because there's an aggregation of these patients in groups that are otherwise not separating out these phenotypes and endotypes, we may not be capturing that full effect. So at least in the rhinology literature, I don't think we have that discrete answer yet of whether there's a discrete role of allergy being a causative factor in chronic sinusitis, but we certainly acknowledge that it's a correlating factor. It affects patients' well-being, it affects patients' outcomes, that it is important aspects of their care to consider. And if you look again at this consensus statement, when it was distilled down specifically to a patient with chronic sinusitis, in terms of the evaluation of allergy, what was the recommendation? And the recommendation was it's an option. I don't pose that today as a right or wrong. I pose that for an awareness, so that when you collaborate and partner with your otolaryngologist or rhinologist to understand perhaps some of the influencing factors of which they're drawing upon in their decision making. And hopefully, that as we continue to collaborate and work together, we can have better, more granular information and data to help drive these decisions in the future. Where Central Compartment came to be is a group of investigators, and this has mostly occurred out of Emory in the United States, as well as out of Australia. In 2014, they noticed that there was a discrete group of patients that had known allergic rhinitis, predominantly perennial allergic rhinitis. However, there were a few patients in their series with seasonal only that had a discrete phenotype identified on endoscopy. And what they specifically identified, as many things start with awareness in these areas in science, is an observation. And the observation was that within the middle meatal space, as represented here on the nasal endoscopy, and this is the same image we've seen before, there was polypoid change as well as frank polyp in this middle meatal space. And that in patients without allergy, first, those patients probably weren't being referred to otolaryngology and rhinology in particular, but in patients that otherwise were, they were not identifying the same pattern of disease of polyps confined to this specific area. And I think this is an observation that many rhinologists and otolaryngologists identify in their practices in our polyp patients, are that most polyp patients do not have polyps confined or limited to this geographic or anatomic area within the paranasal sinuses. And so this was in 2014 when these researchers made this observation. They subsequently published this paper in 2016, and this is the same group that first started trying to describe this in a more rigorous way. This was a retrospective series. It was only 15 patients. But what they tried to identify was patterns within this condition. The inclusion criteria were all patients with allergic rhinitis, and this was proven by skin testing or serum testing. They had histories consistent with that, in as much as chronic sinusitis, and all of those patients received nasal endoscopy and imaging. And it turned out that all of the patients in that very selected cohort type study, admittedly retrospective as well, they had similar patterns of disease, both on endoscopy as well as imaging. And imaging, if I back up a slide, was very similar. This is the same image that I showed a moment ago of the topism of the imaging, or the inflammation was in the central compartment as defined as the ethmoids in the medial compartment of the maxillary sinus or nasal cavity. So this group began collaborating with a group in Australia and furthered the evidence on this idea of central compartment. And this now spans up into the last publication that they put out was in 2019. Although this paper on the bottom was just recently submitted and accepted, and more recently here in 2020, but it's not yet available widely. And what they've shown is similar patterns of this condition in a group of patients with allergic rhinitis. But what is interesting is, naturally, not all patients with AR develop this pattern of sinus disease. And so I'll present some ideas of what we know and what we don't know based on the data in a few moments. But it does appear to be that in a certain group of patients with allergic rhinitis, again, particularly perennial allergic rhinitis, that they can have a concurrent or a pattern of disease that develops into this progression of sinus involvement as well, in a very typical fashion, both on endoscopy and imaging. What they distilled down their perceptions of chronic sinusitis was recently in this paper published in 2019, and this is again the same researchers out of Emory. And if you look at central compartment atopic disease, they believe there is a strong association with inhalant allergy. However, there's certainly significant and notable limitations in the data that we have available. And so this is still mostly centered in observations with low-level evidence that needs to be further replicated as well as strengthened. But if you look in other forms of chronic sinusitis, and I'll direct your attention here to both the polyp patients and the non-polyp patients, you'll see that their impression of the evidence available was that it was equivocal regarding causal associations of allergy and the pathophysiology of chronic sinusitis, which is in contrast to conditions like allergic fungal sinusitis, which there is strong evidence of the associations with allergy. So it's an interesting area for us, particularly as otolaryngologists and rhinologists, that have to make surgical decision-making regarding patients with this specific phenotypic entity that's being proposed for chronic sinusitis. Our pathways, algorithms, clinical practice guidelines are fairly robust in these two domains and these two phenotypes, but admittedly there's a great degree of heterogeneous nature to their patients, both within our chronic sinusitis with polyp patients. So this is a bit of a new idea, particularly for us as surgeons. It's certainly not new in terms of what we've encountered for decades, but how we manage these patients, how we navigate the surgical decision-making discussions with the patients is an area that is certainly timely for us. So here's where central compartment, in terms of its current definitions, exist. And these are rudimentary and based on these low-level evidence thus far. And the proposal for central compartment, as defined by the group, particularly in Emory, has been that this is an IgE-associated inflammation that's localized to those very specific areas within the nasal cavity and out into the paranasal sinuses. The areas that matter significantly to us, particularly as surgeons, are those spaces that we talked about briefly earlier. And I'm going to come back to that on imaging in a moment. But within the nasal cavity, there's three specific spaces that we really look at: the middle meatal space, the superior meatal space, and the sphenoethmoid recess. And I'm going to show you examples of all of those on imaging, because that is a specific area that we really focus our attention, because those are the natural passageways in and out of the sinuses. And we think of the role of surgery, it's really three aims. It's to improve ventilation of the sinuses, improve mucociliary transport out of the sinuses, and then delivery of topical therapies in. And so the conduits, the passageways into the sinuses are through those meatal spaces. And so this is why this condition is so incredibly interesting to us as surgeons, is because the distribution of this disease, although it doesn't tend to be a heavy burden in the paranasal sinuses themselves, except for the ethmoids, the pathways into those sinuses are clearly inflamed and can be obstructed by disease. And that's what matters specifically for us in our surgical decision-making because of those tenets and goals. So central compartment has those polyp, frank polyp, or polypoid changes in those representative areas. It has a characteristic distribution on imaging, and it's being proposed as a variant, a phenotypic variant, I'll qualify that, as chronic sinusitis. The diagnostic criteria is certainly not rigorously defined. The current inclusion criteria are patients that have typical CRS symptoms of nasal congestion, pressure pain, diminished smell, as well as rhinorrhea, and by definition that should be purulent or discolored rhinorrhea, as well in the setting of known inhalant allergies or aeroallergen sensitivities. They have the characteristic imaging endoscopy, which we've talked a lot about already. So the data is limited to retrospective series as well as opinions at this time. There's clearly a strong association with allergic rhinitis, and as I've mentioned, this is typically perennial allergic rhinitis. Asthma is seen in about 50% of the patients as far as we know of currently. Most appear to be never smokers. Most of the patients do not have a history of immunotherapy. We have associations of allergen-specific IgE in tissue samples of these patients. We have unknown relationships with aspirin sensitivity, as well as immunodeficiencies and immunocompromised states, and they're not typically associated with known tissue or peripheral eosinophilia. However, the context of all of this is very limited, low levels of evidence or grade of evidence currently. How these patients are evaluated is similar to any patient with nasal or sinus complaints. You're querying specifically for a history of atopy as well as sinus-specific symptoms. Many of these patients, if they come to us as otolaryngologists or rhinologists, typically have a history of aeroallergen, at least sensitivity testing, and that most patients in this central compartment would be positive to those sensitivities. In the otolaryngology setting, many of these patients have already been treated with intranasal corticosteroids, antihistamines, or oral antihistamines, plus or minus prior trials of oral antibiotics and steroids. And many patients have had at minimum an anterior rhinoscopy, whether it's from their primary provider or one of our referring colleagues. And this picture here just shows what an anterior rhinoscopy can look like. And for us as otolaryngologists, we tend to favor the nasal speculum exam as compared to an otoscope or other tools. So this is just kind of the position that we use, and the tenets of this are high quality nasal speculum as well as light to see anteriorly to the nasal cavity. The tool that we have, however, in otolaryngology is the nasal endoscopy. And so I think it's a powerful tool, and you may find as you either collaborate with your colleagues or review their consultations and notes that they send back to you as the referring provider, that there are different tools that are available in endoscopy. You may have heard of flexible fiber optic laryngoscopy. That's the image here on the left side. This is a flexible scope. This is the part here that actually goes into the patient's upper airway. There's a light source that attaches on the other side of this. Many of us in otolaryngology will just place our eye directly to this area. You do have the ability to hook up a high definition camera, however, to this and then connect that to a recording device and a monitor for ease of viewing as well as manipulation as needed. The advantages of this are that it's widely available, it's generally well tolerated, it's a low diameter of the fiber itself. For a nasal endoscopy, we only tend to use the distal end of this, and so you end up having a bit of redundant fiber that can be sometimes unwieldy to manage, but overall this is a familiar tool, it's a safe tool, it's been around for a very, very long time. Conversely, we have rigid nasal endoscopy, and I think most rhinologists favor this device. Some otolaryngologists, meaning general otolaryngologists, prefer this device, but there are certainly increased costs to have these tools available. And so I'm not presenting this as superiority of one over the other, they're just different. They each have advantages and disadvantages, but a rigid nasal endoscope works with a rigid channel. There's a light source that is attached to the bottom of the rigid endoscope. These come in a variety of angles. You'll see here it says 0 degree, 30, 45, and 70, and that correlates to the beveled edge of the endoscope. These come in a variety of sizes as well. We tend to use the pediatric size in our clinic at UW, which is 2.9 millimeters. You can use your eye directly to the eyepiece here on the endoscope. I think more now than ever that would be not advisable, as it gets you immediately very close to the patient within a few inches. And I think in general, that's something that many of us don't prefer, but certainly now in the times of COVID, that's not something that would be advisable. So the advantage of this is that you, similar to this, you have the ability to hook up a high definition camera to the endoscope connected to a monitor, data storage, and archiving device. But the distinct advantage of this is the optics are significantly better. This permits high definition view. 4K systems are currently available. There's 8K systems coming to market soon. So really high degrees of fidelity. But perhaps most importantly for us as proceduralist surgeons in particular, is it allows us to have a hand free during the examination. And that allows us to then do samples, cultures, biopsies, debridements, whatever we may need to do in-office balloon procedures, turbinate reduction procedures, eustachian tube dilation procedures, whatever it may be. This technique here, this tool permits us to have a hand free. This is a two-hand operation that if you let go here on this distal aspect of the scope, I mentioned before, it becomes unwieldy, and you're not controlling where the movement of this instrument can be in the patient's nasal cavity. So that is a distinct advantage to this outside of the enhanced optics that are permitted by this type of device. Also greater degrees of illumination that can occur. If you've not seen one before, I wanted to show that today too in greater depths and details. So this is our Rhinology office at UW Montlake. We have 4 offices that are built out this way for our patients, or 4 exam rooms rather, that are built out this way. So the patient obviously is in the exam chair through here. This is our tower that we use, and we often just call it our tower. But on this tower, it has a light source. It has an imaging processing unit that is here as well as here. And this is also data archiving and storage. We have the monitor for the surgeon or proceduralist. And then over here is a patient monitor so they can observe their endoscopy. We have full recording capabilities during this. This also permits full in-office procedures, whether it's limited sinus surgery procedures to the balloons and dilations and turbinate reductions and eustachian tube procedures. So the exam room is completely set up for those types of procedures. This is what the patient experience looks like. And I'm going to show a video here on the next slide that shows this in little greater depths and details. But I want to orient you. So obviously the patient is sitting through here. This is our typical position as the surgeon or proceduralist, and then we're looking directly at this monitor. This is what it looks like in real time of a patient having a nasal endoscopy in our clinic. And so you can see that it provides us really a high fidelity view of the nasal cavity. That rigid endoscope here, the proceduralist is using 2 hands because it's a diagnostic procedure. But you can immediately switch that endoscope from the right hand to the left hand and have your right hand free to perform a variety of tasks inside the patient's nose. And so if you've had patients that had sinus surgery and you've seen them or have heard of them going on for debridements after surgery, we do that exclusively with the rigid capabilities and technologies that are available. And so this really is, I think, a very powerful tool for us, particularly as surgeons, not only to give a glimpse of what's occurring inside the nasal cavity, but also to allow us to manipulate and perform procedures in that area. This is what it looks like in terms of the actual endoscopy. So we can, as I mentioned, we can archive and record these, and we can pull them off for later review, remote reviewing, in as much as research studies. And we certainly leverage that significantly for our science programs that we do, as well as educational efforts. And so this is a right-sided nasal endoscopy. This is looking at the nasopharynx. To the right side, you'll see the eustachian tube, and the palate is inferiorly in the bottom of your view. So you can see movement of the palate. This is the middle turbinate here. This is called the sphenoethmoid recess right here. So the sphenoid sinus is going to lead directly superiorly. So this is an area that is those spaces that we look at significantly. This is the middle meatal space, which is going to lead into the maxillary sinus ethmoid and anterior frontal sinus. This is the superior turbinate in the superior meatal space. And obviously all of this represents the nasal cavity. How we use these are that we do try to objectify the data that we collect. And this is a scoring system that's called the Lund-Kennedy scoring system. And it's an endoscopic scoring system used in diagnostic applications of chronic sinusitis. This is a bit of a busy slide, so I'll show you call out the key areas. But what we look for when we perform these nasal endoscopies are polyps, discharge, edema, and crusting. And then the scoring system has whether it's 0, so it's a scale of 0 to 2, with absent at 0, with limitations and degradations within the scoring. For example, if we look at discharge, if it's thin and clear, that would be a score of 1, versus where it's thick and purulent, that would be a score of 2. And so this gets scored out for both sides of the patient's nasal cavity and paranasal sinuses, so a maximum score of 8 on each side of the nasal cavity and sinuses. So if you've seen patients or you share patients with us, you may see this as we report back into our consultations, this scoring system. And so we do use this to follow our outcomes. It's a very powerful tool for us, particularly in our research efforts as well. Imaging is also another important modality that we use. And the first thing I want to say is x-rays are out. No x-rays, no plain films. This has been shown in numerous studies and series, and we have really strong consensus statements and recommendations nationally against the use of plain films for the evaluation of paranasal sinus disease. So this is out. I didn't go into greater depths and detail regarding MR, but in general, we do not use MR for diagnostic purposes either. Some of the challenges with MR outside of cost and access and data acquisition time are that it's a highly sensitive exam and may lend towards false positives and clinically relevant sinus disease. So the imaging modality of choice that we use is CT scan. And I acknowledge that there are many different forms of CT scans available. And what I'm going to propose or present today rather is what we are using at my institution and as a framework of what you may have at your institution or in your offices. And so the CT scan that we use is labeled or called a CT maxillofacial, and that's probably less important of what it's called, and it's more important of what actually is done. And we tend to use a high resolution protocol. And so by high resolution, I mean it's the acquisition of the data in the axial plane. And we use 0.6 millimeter cuts. And I'll speak to a moment of why this is important to us, particularly as otolaryngologists and rhinologists. But part of it is for diagnostic reasons, but more of it is driven by applications of these data for use intraoperatively in some of the technologies that we use. But the imaging acquisition thickness is important in as much as the spaces between each slice. And so this is going to a little deeper dive in imaging, and hopefully it's not too deep, but it is important, particularly for us. We include the sagittal and coronal reformats, and the reason why we want to do this is we really want to understand the anatomy and architecture of the sinuses, and we also really want to understand the pattern of disease in as much as the severity of disease. The last point in terms of nuts and bolts of the ordering of the CT, it's important for us is the idea of gantry tilt. So a quick refresh is a patient lies on the bed for the CT scan. They then are moved into the device that acquires these data, and that is called the gantry, and that's the tube. And as patients are lying in the gantry can be tilted a variety of different degrees. Oftentimes the radiology technicians do that because many patients have amalgam fillings, crowns, implants, partials, dentures, etc., that result in scatter artifact that disrupts the quality and interpretation of the sinuses. And that can be problematic, as you can imagine, for a radiologist as well as for us that are non-radiologists in interpretation of the imaging. And so the way that they try to reconcile that challenge is by tilting the gantry into a plane that is orthogonal to the scatter artifact of the dental amalgam fillings and restorations. The problem with that is for us as surgeons on the downstream is that it's incompatible with some of the software that we use for surgical navigation and planning. And so for us, if you often see a patient referred to an otolaryngologist and they repeat imaging, it's not most often done for diagnostic purposes. It's more often done for surgical planning and its suitability and use in image guidance platforms. Sometimes it is for diagnostic purposes as well too, but that's often a big driver, is more about the navigation than anything else. So when we order imaging, is we specifically order it when either the diagnosis is uncertain, a patient comes to you with a history that's highly suggestive of chronic sinusitis. And the ones we all struggle with are the patients that have years or decades of symptoms that are consistent with that condition, and inconsistent and infrequent touch points with the healthcare system for this problem. Course of antibiotics 5 years ago, maybe some nasal sprays, a year ago, but they only used it for a couple of days. Maybe some over-the-counter medication trials of oral antihistamines or nasal saline. So oftentimes in those patients, at least those are the ones that I often struggle with in terms of initially what's best next steps, balancing all the considerations in a patient's care in terms of cost and radiation exposure, as well as diagnostic information that I require to establish the diagnosis. But in general, it's patients that you have a suspicion for chronic sinusitis. Many patients have already had some form of medical therapy. If they haven't, you certainly could try that before imaging, or you could go ahead and order imaging up front prior to those initiation of trials of therapy. But in general, I think most otolaryngologists position are, if you have a history consistent with chronic sinusitis, some forms of medical therapy would be appropriate to trial first. And if there's failures of that therapy, then proceed on to imaging. Most trials of medical therapy, in my mind, would be defined as at minimum saline irrigations, intranasal corticosteroid spray, and often some course of antibiotics or consideration of oral steroids, again, depending on whether the phenotype of disease that they're presenting with. That is definitely a large topic that we don't have time to unpack today, but in general, that's the concept. The reasons for the imaging are to qualify and quantify the objective evidence of inflammation. What we're looking for are those terms of pacification, mucosal thickening, where it's at in the sinuses, to what extent it is in certain aspects of the sinuses, as well as just distribution of disease. Osteitis and osteoneogenesis are the surrounding and reactive bone changes that occur with patients that have many years of chronic sinusitis. So these are the patients that have decades of chronic sinusitis. You often see discrete thickening of the bone and remodeling of the bone around the paranasal sinuses. You also may see this in patients that have had multiple surgeries. And what has happened historically in sinus surgery is the techniques, fortunately, have evolved significantly. But initially, many stripping techniques were used in the 70s and 80s. And this unfortunately resulted in not only impaired mucociliary transport for these patients long-term, but also significant remodeling and bony reactive changes in those patients too. Often a question comes up about sinus CT screen protocols. These are not wrong. These have advantages, and the idea, the concept is to identify a patient that has objective evidence of inflammation that may otherwise not have a convincing history or endoscopy. But it's important to call out some of the limitations and as well as advantages of this. The advantages are that it tends to be the lowest dose radiation protocol. To my knowledge, it doesn't change the economics, that it's still going through a radiologist interpretation, and there's still associated fees for that, as well as facility fees. The radiation dose protocols, however, in general, have significantly improved in the last few years. Many of our even high resolution CTs have similar radiation doses that are delivered to patients now as compared to years previous, where certainly the radiation dose protocols were much higher. I do think this is an area that probably varies by each imaging center, whether it's a imaging center or whether it's a facility like a hospital or whether it's an in-office application. One of the advantages of the in-office applications that they tout significantly is the lowest dose possible for radiation. The cost of that is perhaps granularity and fidelity, as well as just quality of the actual imaging, particularly as it relates for surgical navigation purposes. But in general, a screen includes typically thick cuts. So these are not the 0.6 millimeter, but they're somewhere between 2 to 5 millimeter cuts. To give you a comparison, often the screen protocols have maybe 20 or 30 images, whereas our high resolution CTs can have anywhere between 700 and 1,000 images. They have a higher probability of gantry tilt because it's being done in a screen protocol, and scatter would significantly impair a data set if you only had 20 images. And how we use these images in terms of objectifying patients' imaging is similar in many ways to endoscopy, in that we do try to provide some objective quantification behind the patient's degrees of opacification. And so to achieve that, there is a validated Lund-Mackay score that is widely used. One of the criticisms, however, with this scoring system is it hasn't been shown to directly correlate with patient symptoms. So it is perhaps important and helpful for research purposes, and it can be another data point to collect when we're looking at outcomes for patients and their quality of life metrics and studies for patients, but there are some limitations in this scoring system as it relates directly to everyday patient care. I mentioned navigation being an important tool. So we use navigation to, we take the imaging data set that we have, that we acquire from patients, we put it into this machine here, which is an image guidance system. And what that provides us is real-time image guidance platform for patients during surgery. We're able to know exactly where we are anatomically during the surgical procedure to confirm surgical position, to stay away things that we don't want to go into, brain and orbits, arteries, veins, and nerve, but make sure that we're addressing all of the paranasal sinus disease during the surgery. So this is based on a preoperative imaging data set that is collected on the patient. It gets input into this software system, which then generates these 3 different views for us that are then cross-referenced to our images as well as the patient. So during surgery, we have direct, immediate feedback of where our surgical instruments are positioned within the patient's paranasal sinuses. It is clearly a powerful tool for us. I won't go as far as saying it's now the standard of care. I don't think we're quite at that point, but it is widely used, and most surgeons use this every day in their practice, and that's certainly true for us at UW. So let's go through some scans and just kind of walk through how we think about scans. And this is not a central compartment patient, but I chose this patient because this patient has unilateral sinus disease, and it gives us an immediate intra-patient comparison for normal versus abnormal. So the first views that we tend to look at, I think, as surgeons, are the coronal views. This is representative of opacification, and it's complete opacification of the right frontal sinus as well as right maxillary sinus, whereas there's complete aeration of the left maxillary and left frontal sinus. The next view would then be into this space here, coming out of the maxillary sinus into that middle meatal space, as well as the nasal cavity. This is in the ethmoid cavity through here. This would be what's called a supraorbital ethmoid cell. Again, you're seeing complete opacification of this area, whereas on the left side, patient left side, that is, right side of the screen, complete aeration of those areas. Maybe a little bit of mucosal thickening right through here, but certainly not opacification as we're seeing it here, or complete opacification. This is a really important space for us. Again, this is that middle meatal space, and this is that confluence area of the frontal, anterior ethmoid, and maxillary sinuses. So this is an area we focus a lot. This is a little further posterior view. You're still seeing the maxillary sinus. You're seeing partial opacification of the right posterior ethmoid, and you're seeing mucosal thickening in the left posterior ethmoid. This is the superior meatal space right through here. So the posterior ethmoids are going to drain into this space and then down into the nasal cavity, into the nasopharynx and beyond. This is the superior turbinate. Here's the skull base. Here's the orbit. And you can see some of the extraocular muscles, optic nerve, cribriform, and then this would be the posterior ethmoid artery coming out in this area right here. So these are all things that we significantly review and highlight, both in our training of our residents and fellows, but also intraoperatively, these are areas for us in terms of risk mitigation and complication avoidance. But for a disease perspective, partial opacification in the right ethmoid, complete opacification in the right maxillary, mucosal thickening in the posterior ethmoid on the left side. This is the sphenoid sinuses, right sphenoid sinus. This is the left sphenoid sinus. No evidence of disease, perhaps scant or trace mucosal thickening right through here, but very, very minimal. This would be some mild mucosal thickening in the right sphenoid sinus, optic nerve. This is orbital apex, but coming into the carotid artery, and then the skull base through here. And then the sella turcica, where the pituitary sits, is going to be immediately posterior to that. We often use numerous views to view this. We're using, so we can look at these areas in different positions. So I just want to show again and highlight, this is the frontal outflow on the patient's right side. So that's a critical area for us. This is the middle meatal space. You can see that really well right through here. This is the superior meatal space that we highlighted. And the area that I haven't talked on is the sphenoethmoid recess. I showed that in endoscopy, but that's this area right here. The sphenoethmoid recess is where the sphenoid sinus drains into the nasal cavity, nasopharynx, and beyond. So again, in highlight of the key areas, the spaces, the entryway, the portals to the sinuses, we're looking at the sphenoethmoid recess here, the superior meatus here, the middle meatus here. Frontal outflow is out through here. It's opacified here. There's some mucosal thickening here. These are just different views, so highlighting the different views we use to see the same exact space. So frontal outflow in a coronal view, frontal outflow in a sagittal view, and then frontal outflow in an axial view. We look at all of these as surgeons because it gives us ideas of the architecture, the geometry, the relative space. You know, what's the distance between skull base and the beak of the nose? What does the geometry look like? How is it configured? What other cells or partitions are in that area? That gives us indicators of the proposed complexity to the area, in as much as just the sinus inflammatory disease. It also helps us understand risk. Where's the skull base? What's the geometry and slope of it? Where's the arteries? Where's the nerves? Are we going to be close to them? Are they in a vulnerable and exposed position? And so these triplanar views, or these 3 different orthogonal views, are really important for us in an area of focus. Here's one showing the right sphenoid in the natural ostium area. This little blip right through here is the ostium of the right sphenoid. You can see it here on the sagittal. You can kind of see where it's showing the right sphenoid ostium. Here's again a view of the sphenoid showing the sella turcica where the pituitary sits, and how the sphenoid has different degrees of aeration of ventilation in this area can affect the relative risk to these structures when we're operating on patients. So let's try to put all this together briefly in the last few minutes we have into the imaging and endoscopy and the paradigm of central compartment disease. So as previous, the history of a patient with central compartment disease. And again, I think particularly as us as otolaryngologists, we tend to view the evaluation of sinus patients in history, endoscopy, and imaging. I think those are the 3 main tenets of our evaluatory tools. Naturally, many other factors are at play: past biopsies and tissue eosinophilia, their peripheral eosinophil counts, if there's questions of immunodeficiency or immune compromised states. Those are all absolutely incorporated into the history, but I wanted to distill it down for brevity in terms of what we think about for this specific condition in central compartment disease. So typically we're looking for a history of AR, mostly perennial allergic rhinitis, but also symptoms consistent with chronic sinusitis. So it's not just sneezing or itchy nose or rhinorrhea or nasal congestion that we're moving to facial pressure and discomfort. We're looking at diminished smell. We're also looking at discolored nasal discharge as well. These patients typically have a positive aeroallergen sensitivity history. SNOT-22 is a patient quality of life questionnaire that we give all of our patients in the Rhinology clinic. This is a validated 22-item question scale that's on a scale of 0 to 5, so a maximum score of 110. We know that the MCID on the SNOT-22 is 10. And so, you know, when we see scores of 20 or higher, we believe that tends to be a more clinically significant disease of chronic sinusitis. There are many nuances, however, to this instrument, including when we start looking at subdomains and other areas within this. There are other validated tools as well that exist out there. So this is not the only tool. I think this is perhaps the most popular tool, at least in the United States. But there are other ones such as the RSDI and others that exist. But this is the tool that we use at UW to evaluate our patients, and you can see the variety of subdomains that we look at, and it's a spectrum beyond nose and sinus specific symptoms, but also in productivity, concentration, depression, and anxiety. We also give our patients a depression screen on every new patient that comes into our clinic as well. And so those are important aspects for us in terms of the quality of life implications and evaluation of these patients. The other aspects of these patients' evaluation or history are that they tend to have equivocal anterior rhinoscopy. There may be some kind of congested turbinate, maybe some stringy mucus, maybe it looks a little dusky, or maybe even get a little glimmer of a polyp or some polypoid change. And sometimes the treatment response history is important. You know, really the patients that were described in this study are patients that have failed prior attempts at, you know, minimal nasal therapies such as intranasal corticosteroids and antihistamines, but also oral antihistamines. And most of the patients in this condition, again, have aeroallergen sensitivity. If they haven't had testing, certainly that would be a strong consideration. But I think, again, most of these patients are probably not going to come initially to us as otolaryngologists. These are patients that are probably going to be in your clinic that you're evaluating. And so I want to kind of provide that different view of how to think about when to consider referral on. if you start seeing some of these other factors beyond allergic rhinitis typical symptoms. So this is a patient with central compartment, and this is the nasal endoscopy that was performed in the office. What we're seeing here is the inferior turbinate. That was a polyp. These are polyps here extending off the middle turbinate. This is the patient's left side nasal septum. Polyp here on the middle turbinate, inferior turbinate. We have stringy mucus, and the tissues look just generally a bit swollen. This is that middle meatal space right through there. I'll play that one more time because I think it's an important endoscopy to see. Inferior turbinate, left side nasal septum, stringy mucus, swollen tissues, polyp change, all coming off the middle turbinate. That's the difference in this central compartment entity, is it's seemingly emanating from that middle turbinate. And the hypothesis for that is that aeroallergens are depositing onto the middle turbinate as well as middle meatal space and generating this potentially IgE-driven inflammation in that area. Why do not all AR patients develop that? I don't know, but this is drawing attention that this could perhaps be a different entity. This is what the patient's CT scan looks like. So similar principles that we've talked about, looking again at the central compartment, at the central compartment, and you'll notice that the degrees of opacification, mucosal thickening, are isolated to those midline aspects of the nasal cavity, that when you look laterally, there's a high degree of aeration within these spaces, including the ethmoids. But the sphenoid in this particular patient appears to be, for the most part, free of the disease. There is some mild mucosal thickening. The maxillary sinuses themselves have very minimal mucosal thickening, if at all, but most of the disease is within the central compartment of the nasal cavity. You can even see some polypoid change that's within the nasal cavity as well, further inferiorly. So, you know, the treatment for these patients are many of those that we would typically use in AR patients, but also in our chronic sinusitis patients, that, you know, trials of nasal saline and oral antihistamines would be appropriate. Trials of intranasal corticosteroids would certainly be consistent with both of these conditions. I think as we start getting more into the chronic sinusitis aspect of the disease, it does raise questions about prednisone or oral antibiotics. There are differing opinions on this in terms of, do you use both prednisone and oral antibiotics? Do you use just oral antibiotics? Do you just use prednisone? It is an area that is steeped in history as well as opinion. In my hands, if a patient has polyps inside their nasal cavity and symptoms consistent with CRS, I tend to use the top four, so nasal saline. I often use oral anti-leukotrienes, not so much oral antihistamines, intranasal corticosteroids, as well as a prednisone taper, and definitely the anti-leukotrienes if they have concurrent history of asthma. If patients fail medical therapy, they are certainly would be a consideration or candidate for surgery at that point. You know, as of it stands right now, these are still polyp patients. We're certainly raising questions about the pathophysiology and best practices in evaluating these patients, understanding this condition, and it's certainly an area that we do not yet have robust data. But if the patient does have bothersome chronic sinusitis specific symptoms, they've failed medical therapy, they have endoscopy and imaging consistent with this degree of objective evidence of inflammation, to me, and what's proposed by the investigators, surgery would be reasonable to consider. And so in my hands, this would be sinus surgery followed by budesonide irrigations. And I would certainly want to continue the collaboration and consideration, at least discuss whether immunotherapy has a role in these patients. And in this setting, I would probably, really want to have a nice discussion about the potential merits of that as well too. But that is certainly not an area that we don't have robust data as it relates specifically to the central compartment disease. So this is that same patient. I've operated on this patient now. This is their 6-month follow-up. And so this is a rigid nasal endoscopy in the office, patient's left side, coming now into the paranasal sinuses. We're starting to see the maxillary sinus here. This is the ethmoid cavity. This is the sphenoid. There's no polyps that I can appreciate, some thin, clear mucus. No appreciable edema that I'm noting. You maybe could say right there, maybe it's trace edema, but this overall is widely patent. This is the skull base. This is the anterior ethmoid artery right through here. This is the frontal sinus. And this is all within that middle meatal space. And we've kind of now connected the middle meatal space, the superior meatal space, and the sphenoethmoid recess. So all of these spaces have now been brought in continuity with each other. This patient is on budesonide irrigations. This patient is on immunotherapy as well. and thus far doing well. And I have not seen recurrence of polyps in this patient, and their quality of life and symptom control as it relates to chronic sinusitis has been durable. At least now this patient's about a year out from their surgery, not 6 months, but this is the 6-month video. So in summary, chronic central compartment atopic disease, it may represent a distinct phenotype, but it does seem to have characteristic clinical patterns, both in endoscopy and imaging in particular. It seems to have consistent backgrounds or relationships with allergic rhinitis, and probably most strongly in perennial allergic rhinitis. I do think rigid endoscopy is my preferred tool of choice, as that permits high quality image data archiving capabilities, acquisition. It allows for procedural interventions immediately, real time in the office, in as much as educational research opportunities that it can also afford. High resolution CT is the imaging modality of choice for me in my hand, and I think that's probably true for most rhinologists. There are certainly many different iterations and possibilities within CT, and those are reasonable considerations, of course, as well too. And in general, it seems at this point, central compartment can benefit from surgery in IT. It certainly does raise questions about if we have patients perhaps go through IT or maybe topical steroid rinses, could we avoid surgery? And I think that's an area that we have to really look at, and hopefully future investigations will continue to answer, hopefully glean insight for that to us and answer those questions. These are some references. I just want to wrap up by thanking you for allowing me to present to you today and share some ideas of how we use these tools in our practices, as well as this new idea of central compartment. Waleed and I are here and want to collaborate with anybody that's interested in that's not only in clinical care, but also in research care too. So feel free to reach out directly to Waleed and I. As I mentioned, Ari will be onboarding with us September 1st, and Jamie is working in earnest as well too. So if there's anything we can do to help support you or collaborate together in the future, we'd love to do that. So thanks again so much for your time and interest in inviting me today.
Ian, thank you very much. See if we have any questions. I have a question. I don't know how it directly relates to this, but one of the things that's been confusing my whole career is a condition we call NARES, or eosinophilic non-allergic rhinitis. And so it's fairly unique to allergy practice that we get mucus, stain it, and look for eosinophils. And we always have had this subgroup of people who are skin test negative and nasal eosinophil positive. And the issue is, do they just have localized IgE disease in their nose? Or are these non-allergic people with a different phenotype of eosinophilia? And I just wonder what you think, and if that would lead to any good coordinated studies between you and your department and our department.
That's a fantastic question, and I'm smiling here because this is something Drew and I, who work together directly, talk about a lot. Because we certainly see this, and Drew shared with me in particular his experience with his non-allergic rhinitis patients that have had benefits with concomitant intranasal antihistamine therapy. And I've noticed the same. And why is it that with negative skin prick testing or serum testing that response would be realized? And my appreciation of the data that we have is that even in non-allergic rhinitis patients, that there is a synergistic effect that's still realized with concomitant therapy, perhaps not to the same degree with patients that are otherwise have proven allergen sensitivity. But it's a fascinating subject. I completely agree. And I think the area that we're leaning in the rhinology specific space is first to call out that I think we're probably 5 to 10 years behind you in allergy in terms of your understanding of the mechanisms of disease. We in sinus disease and the pathophysiology are behind. And that's probably because we don't have as a rich clinician scientist or scientist groups within our country, as well as broadly around the world. And that's been a really call to arms in our societies about enhancing the science and understanding of sinus disease specifically. But my suspicion is where this will go is really a greater appreciation of these mechanisms that occur at the epithelial layer, whether it's epithelial barrier, whether it's host biofilm interactions, whether it's other mechanisms of eosinophils or even IgE that occur at the tissue interface that we just don't fully appreciate yet. But so I don't have an answer for that, but I agree with you completely. I've seen it in my short career as well, and have seen the benefits of concomitant therapy. Drew and I have had quite a few patients where we have had failures of intranasal steroid and antihistamine sprays that we've escalated to intranasal antihistamine and steroid irrigations, and have had success, I think, salvaging some of those patients and providing symptomatic relief. And my hypothesis for that is less to do with the antihistamine and steroid and more about distribution of said drug. And so I do wonder sometimes about, in the mechanisms we use, about distribution in the nasal cavity and the sinuses, and sometimes failures are that and not so much a mechanism that we're otherwise not addressing.
Well, the tissue that you're removing, if we had the right people and the right laboratory, would be a very valuable resource to actually understand the pathophysiology of that disease. We just have to get the right collaboration of people, and that's just an idea for you and Drew and our fellows and your fellows.
Yeah. Absolutely. I know Matt and I have been talking a little bit about that as it kind of relates to AERD, but you're absolutely right. This is what we need, is we need tissue. And we, in rhinology in general, but with collaboration with pathology, have gotten to the point of looking at how many eosinophils exist in high-powered field within the tissue, but that's really about it. And it certainly represents opportunity to go deeper and collaborate with you and others that understand the mechanisms in a greater degree of which perhaps we do as surgeons. But that's also to Waleed's expertise and what he's on board and brings to our group as well too, is a greater understanding and appreciation of those mechanisms too. So I think you're absolutely right. This is a really ripe time for us to develop these collaborations and move that forward.
I know Waleed is listening, and I'll tell the group he's going to be a speaker when we resume in the fall. Any other questions from those online? I know Lahari has been listening. Lahari specifically asked for this very detailed tutorial on CT scans, and I think you illustrated those beautifully for those of us who don't do surgery, and how important the landmarks are for you.
Yeah, thank you. Thank you. Sorry, go ahead, Lahari.
Thank you, Ian. That was wonderful. I learned a lot.
Thank you.
All right, thanks again. We'll be in touch, certainly again in the fall, if not before. Thanks a lot, Ian.
Thank you. It was my pleasure. Thanks again for the invitation.
All right, bye-bye.